Hi, my name is Dr. Naveen Chitran, and I'm an American Board Certified Interventional Cardiologist and lecturer in adult medicine at the University of the West Indies. Today, I'm going to present acute coronary syndromes. This is specifically developed for the Year 4 and Year 5 clinical medical students. Learning objectives. First, we will delve into the pathophysiology of acute coronary syndromes. We will discuss the territories perfused by the different coronary arteries. Also discuss some basic and advanced investigations used in the management of acute coronary syndromes. Also look at the TIMI risk score, which is a risk stratification system. Discuss the pharmacotherapies involved in treating an acute coronary syndrome. Look at revascularization strategies, and finally discuss the ST segment elevation acute coronary syndrome pathway and management. Initially looking at the pathophysiology, the spectrum of acute coronary syndromes includes unstable angina, non-ST elevation acute coronary syndromes, and ST segment elevation acute coronary syndromes. The pathophysiology is on a continuum. Initially in unstable angina, it involves intraplaque hemorrhage, whereas in non-ST elevation MIs, it is due to plaque rupture with subtotal occlusion of the coronary artery. And in ST elevation MI, it is a more fulminant pathophysiology, which is plaque rupture with total occlusion. The electrocardiographic changes in unstable angina are ST depressions with T-wave inversions. In non-ST elevation MIs, it is the development of Q waves, which are pathologic, ST depressions, and T-wave inversions. And ST elevation MIs, it is self-explanatory with ST elevation MIs, Q waves, and the development of a new left bundle branch block. The biomarkers that are preferred are the cardiac troponins I and T. They are normal in unstable angina, abnormal in non-ST elevation MIs, and also abnormal in ST elevation MIs. With respect to the territories, this is very important as it comes in the examinations quite a lot. The LAD artery is represented by leads V1 to V4, and this is called the anterior territory. The circumflex artery is represented by leads 1, AVL, V5, and V6, and this is denoted as the lateral territory. The right coronary artery is also represented by leads 2, 3, and AVF, and this is also classified as the inferior territory. Please make special note of the annotations on the side of the table. Investigations. Some investigations include routine laboratory work such as a complete blood count, comprehensive metabolic panel, glycosylated HbA1c, fasting lipid panel, thyroid function test, cardiac biomarkers, of which cardiac troponins I and T was specifically mentioned, as well as pro-BNP. Of course, you would want to get a 12-lead EKG, and you may consider right-sided and posterior EKGs for an inferior posterior ACS. Chest X-ray is always important to rule out acute aortic dissection and coexisting conditions such as a pneumonia. 2D transthoracic echocardiogram to evaluate the left ventricular ejection fraction, any wall motion abnormalities, and valvular heart disease. It is imperative that these patients go on to cardiac catheterization within 48 hours. There are some special conditions which may accelerate urgent angiography. These include recurrent ischemia at rest despite maximum medical therapy, severely elevated cardiac troponins, severely depressed ST segments, high risk findings on stress testing, depressed LV function, hemodynamic instability, lethal or life-threatening arrhythmias, previous stenting or percutaneous coronary intervention within 6 months, or previous coronary artery bypass grafting. Please make special note of this graph Graphical illustration looking at the rise and fall of certain cardiac biomarkers. As previously acknowledged, cardiac troponin I and Ts are more important. However, some of the prior or now obsolete markers such as CK, LDH, and myoglobin, while not as accurate, they tend to be present early in the onset of acute coronary syndromes. The TIMI risk stratification is an important system. It has been developed by the TIMI group, which is based out of Boston. Basically, the score goes from 0 to 7, which predicts a 4.7 to 40.9% risk of death, MI, urgent revascularization at 14 days. You get a point for age greater than 65, another point for greater than 3 cardiac risk factors, point for prior stenosis, ST segment deviation, greater than 2 anginal events, aspirin use in the last 7 days, and elevated cardiac biomarkers. The pharmacotherapies are important, and in this table we've identified the key regimen or guideline-directed medical therapy, their class, mechanism of action, any contraindications, the relative risk reduction, and the landmark trials that basically prove their efficacy and safety. Please review this table in detail, as there are many test questions that are developed and based on this table. It is important to know that each ACS patient should be on aspirin, either clopidogrel, a low molecular weight heparin, beta blocker, ACE inhibitor, mineral corticoid receptor antagonist, and a high intensity statin. Revascularization strategies primarily include percutaneous coronary intervention, which is previously known as angioplasty, and coronary artery bypass grafting. There are different clinical scenarios, of which each strategy is more useful. As you can see, the key trials are also listed on the right column to guide what strategy should be selected in the different clinical scenarios. Please note that CABG is usually preferred in triple or multivessel disease, left main disease, higher syntax scores, type 2 diabetes, chronic kidney disease, and severe LV dysfunction, whereas PCI is preferred single vessel coronary artery disease and ST segment elevation MIs. Also note, for an ST segment elevation MI, this can be a confusing clinical presentation, and it is important to know that a new left bundle branch block is considered as an ST elevation MI equivalent. There are some clinical situations that mimic an ST elevation MI, and these include early repolarization, normal variant, left ventricular hypertrophy, left bundle branch block, an acute pericarditis, hypokalemia, Brugada syndrome, pulmonary embolism, cardioversion, Prinzmetal's angina, and acute myocardial infarction. With respect to an ST elevation MI, which is a different ballgame to an unstable angina and non-ST elevation MI, there are two questions that need to be asked. Is there a PCI capable facility? And is time to transport to said facility less than 120 minutes? If there is in fact a PCI capable facility and time to transport to this center is less than 120 minutes, the patient should undergo primary percutaneous coronary intervention with a door-to medical device time of less than 90 minutes. This is the preferred or optimal strategy. If, however, there is no PCI capable facility, or if there is one and time to transport to said facility is greater than 120 minutes, the patient should undergo the pharmacoinvasive approach, which is thrombolysis and PCI followed by PCI within the following 24 to 48 hours with a door to needle time of less than 30 minutes, and this is a less optimal strategy. Please note that the fibrinolytic or thrombolytic agent that we use, tenecteplase, it is manufactured with recombinant technology. It is highly fibrin specific, and there's a half-life of 13 minutes. It is usually a single IV bolus administration, and it is only effective in 70% of the ST elevation MI patients. It cannot be used in almost 50% of ST elevation MI patients due to the high prevalence of absolute and relative contraindications. Thus, overall, out of 100 patients that present to the emergency room, thrombolysis will only be effective in approximately 35%. This is an important slide, and it shows that the contraindications and cautions for fibrinolytic therapy in patients with ST elevation MI. Absolute contraindications are listed on the left panel, and relative contraindications are listed on the right panel. Absolute contraindications include any prior intracranial hemorrhage, structural cerebral vascular lesions, malignant intracranial neoplasms, ischemic stroke within 3 months, suspected aortic dissection, active bleeding, significant closed head or facial trauma, intracranial intraspinal surgery, severely uncontrolled hypertension, and prior streptokinase treatment within the 6 months. Relative contraindications include history of chronic or poorly controlled hypertension, hypertensive urgency, history of ischemic stroke greater than 3 months, dementia, intracranial pathology not covered in absolute contraindications, traumatic or prolonged CPR, major surgery, recent internal bleeding, non-compressible vascular punctures, pregnancy, active peptic ulcer, or oral anticoagulant therapy. The complications of acute coronary syndrome are numerous and life-threatening. They include sudden cardiac death, chronic heart failure, a recurrent acute coronary syndrome, life-threatening or lethal arrhythmias such as ventricular tachycardia and fibrillation, left ventricular mural thrombus, aneurysm formation, pericarditis or Dressler syndrome, and there are also mechanical complications such as papillary muscle dysfunction and a ventricular septal defect. That is our summary of acute coronary syndromes. Please note that we have discussed the objectives such as pathophysiology, territories, investigations, TIMI risk score, acute coronary syndrome therapies, revascularization strategies, and ST segment elevation acute coronary syndrome pathways and its management. Thank you for listening to this screencast presentation.